You are listening to Lifeboat for the Whitecoat podcast.
All right. Good morning, everyone, and welcome to the Lifeboat for the Whitecoat podcast. I am Matt Ort, author of Save Your Company, Don't Feed the Beast. And we're here with Amy Schultz and Heather Nill. And our guest today is Dr. Shane Purcell from South Carolina. Pretty well-known doc across the nation, and one of the pioneers related to DPC. So excited to talk today and learn Shane's story and all the things he's done to help this movement. So welcome, Shane.
Thanks a lot. Good to be here. Hopefully we can get some good conversation and some good chatting going on.
Awesome. Maybe we can start off and hear maybe a little bit of your story. Maybe help us understand how you've gotten to where you are today and kind of where you started and what caused you to be so passionate about DPC.
Right. So it's been 20-something years since I finished residency, and I actually did my residency here in Anderson, South Carolina, where I currently live. And like most residents, a lot of people kind of tend to gravitate to the area where they do their residency, to get to know people, to get to know their docs. And so out of residency, I knew I didn't want to really work for the hospital system. I kind of had the entrepreneur spirit basically since I was a kid. My parents really instilled that into me a lot about the importance of money and saving money and banking and just taking care of yourself, taking care of your family. We actually had a bank almost really literally across the street from the little town I grew up in, which had like 2,000 people. And as a kid, I used to ride my bike. I'd get like $5 or something for birthday, and I'd literally ride my bike and go to the little bank and put $5 in the bank. So just trying to think about ways I could save money and make money. Tried to sell my dad's lawnmower when I was little one time, try to make some money, just all kind of crazy stuff. So I've had that spirit a little bit for a long time. And I knew I didn't want to work for someone. So for a big company, corporation. So I took a job with a small independent clinic right out of residency, and is an employed physician, but they still had the traditional fee for service, go attitude, not seeing enough patients. So after a couple of years there, I realized that was not going to work. So ended up doing some urgent care, and then had a vision to do my own urgent care, have my own clinic. And I bought an urgent care who had closed down for about 10 years. I bought it on the other side of the tracks where there wasn't a lot of health care. Seems in most cities, most communities, the healthcare sort of gravitates in one little area. All the doctors are here, the hospital's here, and some places, some communities don't really have a clinic or a place. So I bought a clinic on the other side of town and opened it back up, fixed it up, and got really popular. Within 5 or 6 years, got pretty popular. I had 14 employees and doing urgent care, doing primary care, but still within the system as far as Blue Cross, all the BUCA plans. And then, so Obamacare, Affordable Care Act kind of started kicking in 2014, and things just got crazy. The ICD-10, I don't know if you remember when that happened, ICD-10 codes came about, and that was supposed to be the Y2K of healthcare. Like everybody's like, oh no, if you don't have the codes right, you're going to lose so much money. So there was that scare and Affordable Care Act and some stupid moves on my part as far as business moves. We tried to change EMRs right in the middle of being one of the busiest practices. And I thought it was going to be a good thing. We researched it, did everything, but it ended up being like $100,000 mistake. So I caution people a lot about changing EMRs just because it's a big, big headache. So after that misadventure, I basically saw that was about the time, about 2014 is when direct primary care really became a thing. You start to see articles in medical economics. It's been around for 20 years, I would say, but it really got popular around 2014-ish. More people were doing it. And you had the technology, that's when Hint and Atlas, some of these companies came out with the technology to make it really easy. Before that, and I had a cash practice too. So 2005, that long ago. I had a cash walk in, hey, pay me $45 a visit, $10 strip test. I had like a McDonald's window pricing system for a doctor's office, which nobody in my community was doing at the time. But we didn't have the technology to hold on to credit cards and charge it the way the systems do now. And so when those technologies came around, I was like, man, this is the way to go. I want to go back and do a cash pay system, but have this awesome electronic system to basically do the automatic billing and make it real easy. So learn more about that and learn from Josh and some of the early players in the system. And we started, me and my partner, I have a 50-50 partner, Dr. Amy, and she was inside the system for 17 years and wanted to get out. She was constantly getting, the story, berated because she spent too much time with patients. She couldn't understand why a strip test was $75 when it only cost $2. And so we joined forces, and she left the hospital system, and I kept in my urgent care, but we kind of had a 2-location DPC temporarily while I continued to work on my urgent care. And I used my urgent care was my little moonlighting, so I moonlit in my own urgent care to make money while I build up my DPC practice. And then in 2019, I sold the DPC practice, the urgent care fully, and it was 100% DPC in 2019. But we started our practice in DPC in 2015. So, but I didn't get full, I'd say full until 2019 when I sold my urgent care, and we added on that large employer that we've spoke about before in the community, our county, we brought them on, and it made DPC wide open for us, both me and my partner. We added 2 more doctors because we needed that extra help, and been gangbusters ever since then, basically, not looking back. So I guess you could say I had a vision for a cash practice back in 2005, but we just didn't have the mechanisms back then, the Atlas and Hint, some of these organizations, to make it easier to do. And then when those came on the scene, it was like a no-brainer, right?
Yeah, I think people sometimes maybe forget about the pioneering and how challenging that is before there's really a clear method, before it's a thing. And so it seems to me, I don't know when I met a doc, I think you maybe introduced, maybe who's considered the pioneer of DPC. I forget his name. But starting when you did, I mean, you've got to be probably one of the first DPCs in the nation. Is that fair?
Well, we've been doing it for 10 years. I mean, there's certainly other people like Josh and Ryan Newhofer, who's the original president of the DPC Alliance. Okay. There's people that have been doing it 4 or 5 years longer than I have, but they did it the hard way. I mean, because you didn't have these technologies. And Eric, it was probably Garrison Bliss, is the older gentleman.
That's what I was thinking of. Yeah.
So
he was the first.
He was one of the big ones.
So your official was 14. Of course, you were experimenting before then and thinking about it. But we have a couple in Wisconsin. I think the first ones were like 2012-ish, but still very, very early in the game, right? Before a lot of this was figured out, and people even still today, yet it's still even new enough where you say DPC and they don't know what that means. So. And then the book, it looks like, came out in 2020. Is that right?
I think it was 2020. It's when I got everything finished doing my book, and that was basically in 2019. We spoke, me and David Contorno and some folks from the county municipality. We spoke at the summit, the DPC summit, about the challenges of bringing on a large employer. Some of the name of the talk, I just randomly pulled this name of the talk. Magic, pixie dust, and miracles, because it takes a lot of cobbling together. A lot of things have to go right. The benefits person has to be right. The employer has to really have the courage to put all these things together, and you can get a big community to do it. So we talked, that was a talk, and I said, man, I think there's enough material here. I could share this with other people. So at least the tips and things that we went through, and that's kind of how the book developed, is really just a guide to say, hey, here's some here's how we did it. Here's some mistakes we made.
Mhm.
Think about this as you move forward when you're working with employers.
You are listening to Lifeboat for the Whitecoat podcast.
Yeah, and from what I can tell, you're an inspiration to hundreds of doctors, right? I was in Orlando. Was it Orlando with you? If I get my cities
Uh-huh.
right, there's only about 35 of them I lose track, but and then Dallas. I mean, right? There's a lot of docs there saying, "I'm thinking about this. I'm thinking about this. I'm thinking about this." So there are resources out there now to help them, and then you're also a founding member of the DPC Alliance too, and
Right.
hundreds of docs there that are looking for support and guidance and advice and so
Right.
yeah.
Yeah. So the Alliance is, I think, 750 paying members, and then we have another 300 residents and students who don't pay. So over 1,000 docs
And
in the
nice,
group, all
nice.
looking for mentorship and advocacy ways that we can try to help them understand the DPC model. And
Mhm.
the DPC summit, which you spoke with me last
Mhm.
year, is the largest DPC meeting. It's going to be in New Orleans this year.
Nice.
They're expecting 500 physicians from across the country to come and learn about DPC, and 70% of those physicians are not doing it. They're there to figure out how to do it. And
Perfect.
so
Perfect. Yeah. Do you have any kind of idea like of the fastest growing states or any kind of statistics on how this is growing? I mean, we know in Wisconsin we're getting, I don't know if this will continue, but we had 15 in 2020, and today there's over 130. So that's over 25 per year just in the somewhat rural Wisconsin, right? With around
yeah.
5 or 6 million people. But any states stand out, or areas of the country stand out that are faster moving?
I don't know about faster moving, but
Mhm.
there's seems to be a lot in Kansas. There's a hub in Kansas and Texas,
Mhm.
obviously, because it's a
Yeah.
huge state. North Carolina, there's a lot in North Carolina.
Mhm.
Um, so we actually have the DPC Alliance that you mentioned. We're actually going to be releasing this summer. We just did a huge study. I say it's basically a questionnaire that we did to as many DPC folks as we could. So we're going to have release some information this summer about that study. We have over 500 docs respond to this survey about where they're at, how big they are, how their growth is, what size they are. It's
Mhm.
a lot. It's probably the biggest study that's ever been done. So we'll get a lot of information this summer. And I've only seen just a tiny, tiny bit of what they've collected so far.
Mhm.
So it should be some really good information. And we're planning to hopefully do another a larger one. We just got to get the docs to spend the time to fill those surveys out. And we try to keep it quick, like 4 or 5 minutes, so
Right.
we can just get as much information, because people like you and people who are third party administrators, all these people, a lot of people want this information,
Right.
and we're trying to get it collected from the docs and not from a third party. Um, so we're trying to get as much information as we can. Who's growing? Who's adding docs? How big? How many locations do you have? All this good information that would be helpful.
Yeah, I think that would be very helpful. And we started this Lifeboat for the Whitecoat over a year ago. We've been meeting almost weekly and planning, and our goal really is to support this movement in a couple of ways. One is um, a formal channel to post positions. So to start a practice, which is kind of maybe the fork in the road for the docs, that are in the system. So it's interesting, and I love to hear. Uh, I'm sure there are more, but Dr. Paul Thomas in Michigan is the only other one I'm aware of. Like I said, I'm sure I'm missing many. Maybe Josh in Kansas, but that didn't go into the hospital system. So it's as if you saw it before it even happened. And I know many docs
Mm,
have this story, right? They went in and maybe they even saw it, but they didn't see another path, and they had big student loans or maybe got a big offer or something. But and you and I probably know this pretty well, but I think just for the viewers, and could you maybe just talk about why DPC, right? Why would a doctor not want to go into the hospital system, or at least what would might be some frustrations with that, and advantages of DPC, maybe stuff that you and I talk about almost daily, but aren't obvious to many.
Right. I think everybody knows the biggest limiting factor for the students, and we take students in our office all the time to teach them and share, and we push them to independent practice a lot. In our state, I don't know what Wisconsin is or some other states. Our state's 83% of the physicians are employed. So I think this is more opinion, but I think that's a disservice to our communities because they're working for an employer. And I know for a fact that if you're working for the hospital system, you have to refer within that system. And if there's other independent practices that may be cost effective or surgery centers or imaging centers, places where people can get very good studies and tests and procedures done in a cost effective ways, they're not being sent there. And so that hurts the patients. Obviously, it hurts the community as well because we're just running up costs for no reason. So I spend a lot of time with the students trying to educate them on independent practice, and that we're truly trying to work with the patient, and the indirect care model specifically. The direct means something. It's directly between me and the patient, and hopefully there's not a system or a system administrator or a lawyer or somebody in the room with us. Okay, you can't send this patient to this clinic here. You must send them to our big box hospital system, doc. And so spend a lot of time talking about that. Of course, the biggest issue for students is debt. They're coming out with this massive debt, and so they're like, okay, I've got to get rid of this debt somehow. So I got to do residency. So I'm thinking, hey, I'm going to do dermatology, or I'm going to do some neurology, something where I can make a lot of money so I can get rid of this debt. But there are ways that you can work on the debt issue. I think more and more the government, all these programs are just helping hospital systems keep students inside the system and not even thinking about independent practice. Like the federal, there's a federal program for student loan repayment, and you have to go to a nonprofit center, which most all of our hospitals are nonprofits. My office is not a nonprofit, but I get no support at all. Even though my hospital system, they may buy up all the property in town, they pay no taxes. Their CEOs are making millions of dollars. So it's frustrating. But we try to continue to encourage them, and even through the alliance, like try to get students to come to the summit, try to get them to come to meetings so we can teach them, or at least get them to see that independent practice is doable. I think that just being there and saying, hey, I've been doing this for 10 years and I make a good living. I have with my family. I'm not sitting at home at 9 o'clock at night on a computer trying to fill out charts. I don't have to see 35 people a day. I have time to go on vacation. Being your own boss, being if you're in charge, you're in charge. So the buck stops with you, but at least you get to make that decision. You don't have to go to someone in a three-piece suit and behind a $20,000 desk to try to get permission to order a new computer that just broke on you. So try to list it all out, and it's really about the entrepreneur spirit. Either you can't really force that on somebody, and my concern is as we go through more and more of the students, they don't have that. They just want to just get paid and go home. And I think it's up for us and people like you guys, because you are business folks. We need to impress on them that, hey, you can do this. We can help you. There's people out there, resources. There's CEOs. There's CPAs and banking people. There's all kind of people that can help you do this. You don't have to do it on your own. Mentors, and so they just don't know. They're just people just don't know that it can be done.
You are listening to Lifeboat for the Whitecoat podcast.
Yeah, and even if a doctor is not business minded or entrepreneurial in the same way, at 10 years old, I was thinking the same way. What business could I start? And not everybody's like that, and that's okay. But I'll tell you, but even if you're not like that, I still think a doctor goes to medical school and finishes residency, right? Even if it's not about money or business, they're still wanting to take care of people. They're still wanting to treat patients. And I don't, you're right. You say these patient panels of 2,000 to 2,500. I don't think there's any way you could do it in that environment, even if you don't even care about the charges or the business side, right? You're rushed. 30
Right.
patients a day versus, right? What does a physician in your office see, or how many patients do you see a
Yeah.
day?
We see 6 to 8 in the office,
Yeah.
and then we'll communicate in other ways, text and email with maybe 10 or 12, 15 other throughout the day, do some emails, do some
Hmm.
texting,
Hmm.
tell some people how to think. But in the office, 10 people would be a lot in one
Right.
day.
So you're not rushed, right? You can have that relationship just like it was 30 or 40 years ago. And yeah, and I think coming out of school certainly is a challenge because of the debt, maybe. But it seems to me most are, in the hospital system, they saw that as the only path, or kind of got lured in. And we have Heather Nill here with US Bank. And
Hmm.
so I think there are a variety of things. I heard, I think it was Dallas. I'm trying to remember. One doc said, you can start these things with very little resources. Maybe you remember, but it was a cell phone and two other things, and I can't remember. I mean, this was bare bones, right?
Yep.
Here's what you need to start a practice. But Heather, for instance, can offer running credit, and so you don't have to take a big loan or something, right? If a doctor's been in the hospital system, maybe they've paid off their house, maybe they've got some savings, and within a couple of years of that saved money, they can be going and then just use some running credit or something like that. Any thoughts there of the financial side?
Yeah. Well, I can tell you, we started with a $20,000 line of credit. We just went
Mhm.
to a local bank that we had been using, and with our own personal, wasn't backed up by anything. It was just a personal line of credit,
Mhm.
$20,000. Now, I will say that obviously I was making revenue. I had a cash revenue through my urgent care, so we were all moonlighting in some way to make
Mhm.
extra money. And then my partner, she basically, her husband, had his own job, so she took a huge pay cut, for 6 months, where she didn't get paid as much to build up the practice. So you can, that's not really a loan, but it is. I mean, you're loaning money from yourself and time from yourself. So, but really, to get the chairs and the tables and the things that we needed to staff a building, we spent $20,000, and most of that money was because my partner brought her medical assistant with her, so we had a salary. We had to pay her a salary right off the bat, and so a generous amount of that went to that one salary. Really, salary
Mhm.
and benefits for that one person. Which, if you're starting from scratch, you don't necessarily have to do that. You can it
Mhm.
can just be you and a cell phone and a table, basically, to exam
Mhm.
people, and a stethoscope. You got to have one of
Oh,
those.
that's what it was. Stethoscope, and I forget, a
Yeah,
room or something. Yeah.
yeah,
Okay. Yeah.
I spoke to a doctor recently who was looking to go out on her own. She's more in rural Montana, I think it was. And it is about getting creative. I even just told her, I said, do you have a car? Maybe build your practice by doing in-home visits and start that way, just building that word of mouth while you're moonlighting and earning extra income elsewhere. So when there's a will, there's a way. That is for sure.
oh
When you're
yeah.
talking to new doctors who are still on the fence about whether to go to a hospital system or on their own, what are your top 5 pieces of advice to start with?
Well, if they're even considering DPC, I always say, hey, budget, budget, budget. What's your budget? Can you budget at home? If you have a loan that you have to pay, are those deferred, or what do if you're paying $2,000 a month, you got to come up with that money for that loan. You know, is there a spouse involved, significant other involved? Is there other money coming in one way or the other that can help you? That's a big step in the right direction of whether do they need income. Moonlighting is a big one that frequent people say, where can I moonlight, what can I moonlight, how can I do that? those issues, and then trying to really, as we've been saying, like, you don't need a lot of money to get started. You could either get a small loan, or if you've done some moonlighting, maybe save $5,000-8,000 up so you can get what you need to get started. And then the difference would be the hardest part is when they're coming out of residency, they're going to get money thrown at them from these hospital systems that says, hey, here's $10,000 bonus, and we're going to pay you $250,000 a year. What you can't see, what I try to teach them is that you don't see the golden handcuffs they're about to put on you. Once you get that money and that loan, you're kind of locked in for 3 or 5 years, and then you go buy a house, you go buy your Mercedes, and the next thing you know, kids are in private school, and the next thing you know, when that contract's up, you're like, I can't get out of this because my debt and what I'm paying every month, I can't go do DPC. I have to have this much money coming in. So I spend a lot of time with students trying to teach them, like, hey, can you continue to live like a student, continue to live like a resident, get those loans paid down, and then you can, as Dave Ramsey says, you live like nobody today so you can live like nobody tomorrow. And trying to get them to see that is very hard because they want to go and get all these nice things. So we have to limit that.
You are listening to Lifeboat for the Whitecoat podcast.
Especially after so long of sacrifice too, I think there's probably a feeling of, right, like, it's time. I've sacrificed for what, 12-ish or give or take years. And I think one thing I always, with my background in HR too, and people would always ask me for advice about, should I try to get this other job or go back to school? And we work, let's just say, roughly from 20 to 60 or 65. So we have 40, 45 years. I think sometimes we think short term. If there are doctors, right, maybe they're in their 30s or even 40s or any age really, but there's a lot of career left. And it's kind of like, how long do you, right? I don't know what percentage are unhappy or frustrated or miserable. Maybe you have some insight, but I think it's a fair number. I've had half, 50% or more thrown at me. So I think sometimes we just got to think about this long career. Can I do this for 25 more years? Or is it better, what's worse? Or is it better to take a risk, maybe a small risk or an educated risk, and look into this thing, right?
I think the risks are low. And I think that's one thing that Heather can share with folks too, is that so you get a small loan, $5,000-8,000 loan. You're gonna try this. You're gonna give it your all. And DPC is not for everyone. There are DPCs that don't make it, and for a lot of reasons. Health reasons, death in the family, run out of money, your pricing is not right. There's reasons for it, but for the risk is not that high. I mean, it seems like, oh, if I don't make this work, I'm in deep trouble. And some of that is helpful to put a little pressure on you to really get motivated to do it. But you can always pick up the phone and call your local hospital, and they'll be happy to give you a job. There are always people in primary care. You can find a job in primary care, and you can get paid plenty of money, to go work in the shackles of the hospital system. Now, you're going to suffer for it. Obviously, you're going to have to see 30 people a day, and you're going to be charting at night, and you're not going to have family time. But you can always go get a job doing family medicine somewhere. So the risk is pretty low once you really look at it and think about it. You'll have a little more debt, if you borrow a little bit of money, but you can always get a job for sure in medicine.
I mean, you were just saying the budgeting is very important. And when I meet with any type of doctor, whether it's a dentist or a medical doctor or it doesn't matter. It comes down to two things. It's what do you own and what do you owe? And I think you nailed it on the head with just managing your expenses. I had a friend once who got out of medical school, bought all of the fancy things, and they call it deferred gratification. And you're right. It's like they've waited so long and they get that big paycheck and they just want to go wild. But that too has long-term consequences and then happiness and time. You talked about risk too. You're giving up so much when you trade stuff for your time and your happiness and joy. I mean, really, it's just hard to see when you're in it and when you're feeling that pressure.
And some people, it's interesting. Some people say that, like Matt was talking about starting DPC out of residency. Some people say you shouldn't probably do that. You should go work in the system and really feel the pressure and see how bad it is, and then go start your DPC. So I don't know if people need to suffer like that. I think you could do it right out of residency would probably be just as wise, but sometimes it does take the crucible of working in a system to really think, oh my God, I can't do this for 30 years. There's no way. I have to get out.
You are listening to Lifeboat for the Whitecoat podcast.
Do you think, Dr. Purcell, that the hospital system will ever see the error of their ways and try to correct? Because as a consumer, we see them market this beautiful healthcare system and caring physicians and a caring environment, but there is nothing worse than going to an urgent care or emergency room visit and then getting 5 or 6 bills after the fact, and you don't even have any voice or legs to stand on, and you're looking at these bills saying, oh my gosh, I would have never taken that test or that aspirin or anything if I knew it would have cost me 100x sometimes. Do you see the system changing with the awareness that's increasing with DPC, or is it just too big a beast to swallow, to use Matt's book?
Yeah, I think there's opportunities there. I mean, huge opportunities for smart people, for business people to make better hospitals. One of the biggest problems right now is, and one of the most damning things that happened with the Affordable Care Act is they basically banned physicians from owning hospitals. So, you can own a hospital as a business person. Matt can own one if he wants to. My janitor at my office can own one, but I can't own a hospital. So that's a huge problem that, even if we had a group of physicians in South Carolina who wanted to get together and start our own hospital, something better that would be patient-centered, we can't do it. So it's business people that do it, but there's a lot of talk and rumblings about, in South Carolina, they just repealed the certificate of need law, and it goes away for hospitals in 2026, I think, or 2027. So meaning that you can open up a hospital and there's nothing anybody in the state can do about it. So all of you could basically get together and say, hey, we're going to open up a cash-based, really friendly hospital right in the middle of South Carolina, and the hospital systems can't do anything about it as far as certificate of need. So there are talks and rumblings in our state about thinking about ways to do that. I have a really close buddy who's in DPC, Dr. Jerome IEI, Palmetto Proactive, and he has a dream of having a small hospital, basically a cash-based direct pay hospital. Nice. where you combine like an employer. So let's say you have 10,000 people, right? And you have maybe it's 10 employers and they all have 1,000 people and they're all paying in to this one pot, and you have a small 20-bed, acute care only hospital. I'm not talking about a hospital that has surgery and everything, but 90% of the stuff that people are in the hospital for today, they don't even need to, there's simple things. We're not even talking about ICU, but like pneumonias and kidney infections, things that people are in the hospital for a day or two. You could do that in a small, almost like a home base. You could do that at home almost with a really good internal medicine doctor. And you're talking about saving tens of thousands of dollars for that employer. So he has a vision to try to do that one day, which would be an incredible thing if you linked up employers and basically had your own hospitalist and your own, urgent care docs, and everybody was paid, and you could take care of 95% of everything with that system. It's only the serious, true catastrophic emergencies that would have to go to a bigger system.
Yeah, I would agree. It seems to me if this free market movement takes off, this direct care movement, which it is, that the hospitals are going to be forced to change, and that they become almost inpatient centers, and maybe even down the road we can get fair prices for that too. And so we're coming up on time, Dr. Shane. So I always like to kind of finish with one kind of bring it home question. In that as we grow this following, and we talk to doctors across the nation, there's going to be, and maybe already are, doctors within hospitals, within hospital systems listening, and they're frustrated and they don't know anything about this. What would your advice to them be based on your experience and based on your training and qualifications? What would you tell them? Just maybe you can guess what they're thinking or asking themselves.
Yeah. Well, I think the first thing is that you don't have to keep doing it that way. You don't have to stay in the system. And we focus on primary care, and there's a lot of primary care issues that we deal with. But I mean, even specialists, if you're a rheumatologist or neurologist, if you're in a system that's really bad, you don't have to be in that anymore. There's direct specialty care people that are out there helping people set up their own cash clinics and connecting with employers that really would prefer to pay you directly. So there are direct pay options out there. There are mentors out there. I can guarantee pretty much if you're sitting in any community that has a hospital system, I guarantee you somewhere nearby within 50 miles, there's a DPC physician, a direct care doc that you can reach out to. Go to DPC Frontier page, go to DPC Alliance page. There's maps there that can connect you with a local DPC physician, and just reach out. I think people will find, and you can attest to this, Matt, that direct primary care physicians are some of the friendliest, open and honest people that will connect with you and really try to help you to advance, because they want other people to get out of the system and help their patients and help communities. We see DPC at the Alliance as a life raft, kind of like you guys are starting your new company. So it is a life raft to try to support and help those people, and just reach out to a DPC doc in your community, and say, hey, let's go get coffee. Let me go buy you a cup of coffee. Tell me how this works. And there's plenty of, obviously you can YouTube DPC. There's tons of videos out there. There's tons of people out there doing it. But I think a face-to-face connection with somebody in your area where you can ask questions is really the way to get down to the bottom of it.
I would agree. I've had the same experience. There's something and to be said about morale, right? If you can be a very positive, talented person, but if you're in an overburdened system and you're just coding all day and seeing 30 patients, as many different examples, right? Hard to keep your morale high and hard to go above and beyond for your patients. So I've had a great privilege to meet DPC docs across the nation. And they're all very helpful and very positive, and they're busy. We're all busy, but they have time and they make time to chat or help. And so maybe it's what all prospective docs dreamed of before they started med school, right? This is maybe the dream path, if you will. So I just want to thank you for your time today, Dr. Shane, and all of your wisdom and your experience, and for your courage in getting out there and pioneering different ways. And I hope it's helpful to our listeners to be able to see this. We talk with a lot of docs, and like they say, the first thing I did was watch like 20 podcasts. I watched everything that was out there. These are smart people. They go out and they soak it up, and they can learn it very fast. And so hopefully we can be one of those resources for them. So just want to thank you again. And
very good.
So thanks again.
This concludes this episode of Lifeboat for the Whitecoat podcast. Please make sure you visit whitecoatlifeboat.com.